A warm welcome from my country, Ethiopia. It is truly a beautiful country with beautiful people and a fascinating history. But it is not without its challenges, especially in healthcare. Ethiopia is one of the most populous countries in Africa, with 112 million inhabitants, which is approximately 10% of the continent's entire population. In 2006, about 85% of the population was living in rural areas, the rest living in urban areas. In the urban communities, there is high unemployment with a large informal economy.
The political unrest in Ethiopia started in the mid-1970s when the last emperor was overthrown by the military, who established a totalitarian rule where civil liberties were limited. A long civil war ensued, lasting from 1974 to 1991. A transitional government was established, only to be then followed by a separatist war in 1993, which resulted in Eritrea separating from Ethiopia. Peace was only declared between the two nations as recently as July 2018. This has now sadly been followed by further civil war from November 2020 to the present day between the federal government and the regional government of the Tigray province. Ethiopia is a poor country that has struggled with drought, famines, overpopulation, poverty, and political instability. The result is that Ethiopia is one of the poorest countries in the world, ranking 169 out of 179 on the United Nations Human Development Index. 44% of the population lives below the National Poverty Index, and 77.5% lives on less than $2 per day. Unsurprisingly, this has had a major health impact on the people of Ethiopia. A lack of finance, poor strategy, and weak government has meant the universal health care is minimal. Progress in healthcare in Ethiopia also suffered during the military years, when many of the country's doctors either emigrated or never returned from their training abroad. Although the socialist regime fell in 1991, many of the negative effects have not been reversed. An insufficient workforce is evident. The density of medical doctors, health officers, nurses and midwives is less than 1 per 1,000 population, totaling less than 100,000 nationwide. In the rest of Africa, this density is just over 2 per 1,000, and the WHO minimum stands at 4.45 per 1,000 population.
Ethiopia needs over 10,000 orthopaedic surgeons, but presently they have less than 500, who are serving a massive population of over 100 million. Orthopaedic practice and training does continue to take great strides in Ethiopia, with newly qualified consultants really driving things forward. There are now 2 large training centres in the capital, run by Addis Ababa University through the Black Lion Hospital and St Paul's University through Avet Hospital. There are also training programmes established in Bahir Dar, Gondar, Hawassa and Mekelle. The need to support these training programmes and their many trainees is as great as ever. New orthopaedic departments are also being born at many other institutions, where recently qualified surgeons are returning to set up their practice. Of note, surgeons at Hawassa have been supported by the Northwest Orthopaedic Trauma Alliance for Africa, or NOTA. In Gondar, they've been supported by the Leicester Orthopaedic Project, and because of this they've been able to develop and grow orthopaedic services with the support of WOC UK members. Also, Bristol are currently developing a link with Bahir Dar, known as the Bahir Dar Orthopaedic Network in exchange with Severn, or Bones. Other hospitals in Ethiopia are seeking similar support.
Gondar is a city located in the Amhara region, in the northwest of Ethiopia. University of Gondar Hospital, in the northern Ethiopia, is a 400-bed teaching hospital attached to the University of Gondar, taking referrals from 4 surrounding district hospitals and serving a population of approximately 4 million across the region. It's a university hospital and plays an important role in teaching both medical and nursing students from the region. The trauma orthopedic department is relatively new, having separated from the Department of General Surgery in 2019. It has 5 orthopedic consultants and approximately 30 inpatient beds. The on-call service is led by registrar-level doctors. Previous orthopedic visitors have identified the challenge faced with managing bone infection, often as sequelae to open fracture. We lack suitable trauma implants, techniques to address bone voids, microbiology support, plastic surgery expertise, and modern methods of wound care. Most challenging is the delayed nature of presentation and also the lack of both patient and institutional resources for lengthy, complex methods of treatment. This 8-month-old infant is typical of the challenging cases we encounter. Fortunately, they live close to Gondar, but like most rural Ethiopians, they attended a traditional healer first, which led to a 3-month delay from the initial acute sepsis. Cloxacillin is the usual first-line antibiotic in Ethiopia, based on the belief that gram-positive cocci are the most common infection. Our microbiology services are poor nationally, with samples or results often lost due to a paper-based administration. Across Ethiopia and much of Africa, techniques to manage dead space are very limited. Bone cement and vac dressings, if at all available, are prohibitively expensive. Most of us are familiar with Elizarov method, but even this low-tech solution is rarely available. Our first plastic surgical consultant appointment in Gondar is expected in 2022. And with that, we hope to have some allied expertise.
I would like to echo what Dr. Caleb has just said. Cases often present late, having travelled a long way to reach us, and with delays following misguided and inadequate treatments from traditional healers. This 12-year-old boy came from around 200 kilometres away and had symptoms for over a year. Cases of severe infection of the femur will often form a structural involucrum, but this is less likely in the tibia if there is segmental involvement. There are various options for salvage once sequestrectomy and debridement is complete. Elizarov techniques, Masquelet-induced membrane, and various fibula transfers can all be considered. There is a real need for cheap and readily available bone cement and also reliable negative pressure dressing technology in Africa. Also, to give perspective, this patient has been an inpatient with us since his first surgery in March of this year up until now. And it's not just him, but also his elder sister, who has been his main caregiver, both of them having to miss out on education for the whole year. It's a real pleasure and honour to join you at the BOA 2021, even if it's only via a recorded video, especially given Aberdeen's historical contribution to our understanding of bone sepsis. In the late 1800s, Alexander Ogston identified and named Staphylococcus aureus, based on his own microscopy and culture of material from patients with infection. Scotland also contributed to the first study on osteomyelitis, published in 1948, which showed a 33% mortality reduced to 10% with the use of penicillin. Observations of penicillin-resistant disease followed. For me and my colleagues in Ethiopia, this is the juncture where time has now stood still. Studies from Glasgow, amongst other places, have shown favourable declines of both acute and subacute hematogenous osteomyelitis in children, with fewer patients needing surgery. That is sadly not encountered here in Ethiopia. The minimal improvements in nutrition and the general standard of living mean that our patients continue to suffer from high rates of osteomyelitis. They can rarely be treated without surgery owing to complex presentations and high rates of complications.